नाम कविता खारबंदा है। मेरी उम्र 48 साल है और मैं ओबेसिटी से बहुत परेशान हूँ। मैं ऑपरेशन करवाना चाहती हूँ क्योंकि मेरे जॉइंट्स पेन होते हैं, कराटे वगैरह आते हैं।
चलने से सांस में तकलीफ हो जाती थी, थकावट हो जाती थी, रात को खराटे बहुत लेता था।
टोटल हर मंथ 5 kgs इंक्रीज़ हो रहा था और काफ़ी कंट्रोल किया, प्रॉपर डाइट फॉलो करी, लेकिन उसके बाद भी 1 kg मतलब हाफ kg का भी फ़र्क नहीं पड़ा।
Recently, obesity has also been declared a disease by WHO. The obesity is the collection of the excess fat in the body, and usually it is measured by body mass index. We call this as BMI, body mass index, and this is weight in kilogram divided by meter height in meter square. So what happens is that whenever any obese patient comes to us in OPD, then we look for all the comorbidities. Comorbidities in the form of hypertension, diabetes, sleep apnea, respiratory diseases, heart diseases, varicose veins, and so on and so forth. Then, if everything is okay, the patient is admitted one day prior to the hospital, and then we go in for surgery the next very day. There are basically many kinds of surgeries, but they are restrictive or they are malabsorptive. So what we believe is that there are two major kinds of surgeries. One is called as sleeve gastrectomy and other is called as gastric bypass. The surgery is performed by two methods. One is laparoscopy, another is robotic. The laparoscopic, once all the investigations are complete, once the clearance has been given, then we make 4 or 5 punctures onto the anterior abdominal wall, and these punctures are of 12 millimeter to 5 millimeter. Some are 12 millimeter, some are 10, some are 5, so that ultimately these long rigid instruments go into the peritoneal cavity, carbon dioxide is insufflated, and then, for example, if we are doing the sleeve gastrectomy, then we take the portion of the stomach out by putting in the staplers, and once these staplers, 5 or 6 staplers have been fired, then we take the portion of the stomach out, we over suture it just to be 100% safe and sure, over sew the staple line, and then ultimately we leave the drain for 48 hours, and then the patients are absolutely fine. And once the capacity of the stomach is reduced to 100 ml, the excess portion of the stomach is taken out. What happens is the hormones, for example, ghrelin hormone, which is present here, that is also taken out. And ghrelin hormone is called as hunger hormone. So once the hunger hormone is knocked off, the patients do not have any hunger, they do not have the craving, they do not have the sensation that they want to eat more, and that is the way the metabolism changes. Whereas if we are doing the gastric bypass surgery, then we make a small pouch of the stomach, we disconnect the intestines approximately 50 centimeters from the fixed area and connect it to the stomach, and thus the major portion of the stomach is bypassed, and these patients also we have just 4 or 5 small punctures and the patient is able to move around in the evening or next very day, and the patients are comfortable. For those patients, for super obese patients of the BMI of maybe 84, 83, 89, we offer robotic surgery. In this, the robotic arms are there which take care of the 10 inches or 12 inches of the fat of the human body and then lift it up, and then we are able to do the stapling and suturing, and ultimately we get the best possible results in those kind of situations.
सर्जरी 21 डेज़ हो गए हैं। महसूस यही है कि पहले जितनी भूख लग रही थी अब भूख नहीं लगती ज़्यादा। भूख लगती है, एक गिलास जूस, लिक्विड, कोई भी लिक्विड लिया तो उससे पेट बिल्कुल कम्प्लीटली फुल हो जा रहा है। अब मतलब खाने की नीड नहीं है ज़्यादा।
We encourage people to take non-vegetarian. We encourage people, patients or people to take more of protein diet. We request them to take fish, chicken, meat and so on and so forth, so that ultimately it is becoming a more of a high protein diet, low carbohydrate diet and low fat diet. Then the patients ultimately carry on losing weight, the muscle mass is maintained, the fat is lost, and the patients definitely feel happy. In gastric bypass operations, we definitely need medications. That what we do is that we get the investigations. We get the baseline investigations. After 3 months, again, few investigations, so that if there is any deficiency, then we will take care. Otherwise, we do not. Similarly, in sleeve gastrectomy also, most of the times, most of the patients do not require long-term maintenance therapy. But if there is a deficiency, definitely we love to give them B-complex, Pentodac and iron, so that ultimately the patients feel comfortable. They start losing weight right from day one. Patients lose weight of the order of 7 to 10 kg in the first week itself, and next very week around 5 to 6 kg, next week around 3 to 4 kg, and then 2 to 1 kg, and so on and so forth. They carry on losing weight for around 6 months, and after that it starts stabilizing, and after 2 years there is no weight loss. It becomes more or less stationary. Once the patient sheds around 10 kg, 12 kg, the joint pains also go off. Ultimately, osteoarthritis also gets treated. The advantage of all this is that the metabolic changes occur in the body. So with the metabolic surgery, these features, hypertension, diabetes, sleep apnea, snoring, heart disease, lung disease, and so on and so forth, so they are treated or they are cured along with the weight loss. Thanks to so many fast food joints, that the people or the children of the age of 14 to 16 to 18, they take lot of burgers and pizzas and whatnot, and because of this habit of junk eating, they tend to increase weight, and we have operated the children of 14 or 16 years who are having a weight of 165 kg or 185 kg. These patients, when they gain that much of weight, it is next to impossible to reduce weight. So for those kind of patients also, we do this bariatric surgery, and ultimately the patients start losing weight, and once they lose weight, they start doing exercises, and ultimately they come back to normalcy in their lives. Maybe some nutritional deficiency in some patients who are already compromised. So those patients definitely, as I mentioned, that we can have the test done and then replace it. Or another, I would say, a negative aspect of these kind of surgeries is that in the initial phase, maybe after 3 months, patients can have hair loss. and that hair loss is a transient period, and that is because of the biotin deficiency. And we give the biotin capsules, plus we give them the shampoos and the high protein diet and the zinc supplementation, so that ultimately the hair loss is not there, or if it is there, it is reversible and the patients have a better hair. Are there any other implications or other complications? Yes. If we do not do the surgery in a perfect manner, if we do not put the staplers rightly, and then we do not put the sutures rightly, then the chances are that one can have a leak. And if the leak is there, it is definitely a difficult problem to treat. Our philosophy is that a split second becomes eternal. That if we are doing the surgery, then we do not go by the clock, but we go by the compass, so that the direction is right, the patients are offered the best, and the patients ultimately get our best.
ऐसे मेरे को पहले डायबिटीज़ भी थी, अब डायबिटीज़ थोड़ी कम हो रही है। मेरे पैर पे जख्म था, वो जख्म अब ठीक होना चालू हुआ है।
अच्छा।
सर्जरी के बाद ये 2 साल से मैं इलाज करा रहा था, बड़े से बड़े डॉक्टर को दिखाया, जख्म ठीक होता था फिर ख़राब हो जाता था।
What we do is that every month we have something called as obesity support group meeting. We have patients who have been operated upon, they come, and the patients who are potential patients who are thinking that they should go in for surgery or not. So we call them, and then we give different lectures. Maybe I speak for a few minutes on obesity surgery. My physiotherapist, my dietitians, they speak about the post-operative care of the obese patients, and then they are left to interact with each other. So what we have realized in last few years, since we have been practicing this bariatric surgery, is that if the patients who have been operated upon and the patients who have to be operated upon, or who are the potential patients, if we mix them, if we ask them to interact with each other, then our conversion rate definitely is higher. That these patients get convinced early as compared to when we teach them or when we tell them that they should go in for surgery. Because in that kind of support group meeting, we have people who have been operated upon maybe 1 month back, 6 months back, 1 year back, 6 years back. So this is our hallmark in Global and Gangaram, that we have a relationship with the family, we have a relationship with the patient, and so ultimately it becomes a well knit family, and this relationship goes for a long time.